Good stuff. I think we are rolling, Spencer.
Cool.
One thing I love to do since we have folks calling from across the country is just check in on where people are dialing in from. So, Spencer, where are you calling in from today?
I am calling in from a town or a city called Frisco, Texas, which is just north of Dallas, about 30 minutes or so.
Nice. What's the temperature in Frisco, Texas?
I don't even want to look. I know it was like 100 plus, man. I thought we were past it, and no, yeah. You
Well,
calling
very
in,
cool.
Mr.
Yeah, it's out there. I'm in the mountains. I'm calling in from Park City, Utah. And I know folks are joining us right now. We've got a bunch of people rolling in. So maybe I think a fun thing too is why don't you just chime in the chat where you are calling in from. And it's fun for us to get a sense for where across the country people are dialed in from.
Yeah.
And yeah.
Oh, I saw Dallas. I just saw Dallas.
We've got some more Texas. Farzad, good to see you. Rockville, Maryland. We got San Diego, Oceanside. Got a bunch of West Coasters, which is cool. And East Coast.
San Fran.
Massachusetts, SF. Love it.
Wichita.
Awesome. Welcome, Melissa, Wichita, Texas. A lot of folks. It turns out that saving money on healthcare is a topic that's interesting. Yeah, in many different geographies. Terry, welcome from Boston. It's great.
Very cool.
Well,
I love the fact that in today's age, we can talk to people across the entire United States in one fell swoop from the comfort of our offices or homes. So it's pretty cool.
That is definitely a benefit. Yes, for sure. Awesome. For those, I see we've got a couple of folks joining. People rolling in. We're going to give another minute or so for people to join, and then we'll dive in with intros and hit the topic. For those that are just getting in, why don't you drop into the chat where you're calling in from around the country, and love to see where folks are coming in from. I think I was looking at the registration list. It's a lot of fun. We've got folks that are Nava clients today. We've got folks that are, I think, probably in the journey right now of potentially working with us. We've got folks that I think the first interaction that they've had with either probably your firm or ours will be this webinar, learning more about how to save money on healthcare. So a lot of fun. Well, good stuff. I think we're there. A couple minutes in. Spencer, are you ready to dive in?
Ready to go, man.
Let's do it. Craig, welcome from we got Arizona in the house. Melissa, welcome from Texas. Good cross section. I think we've got West Coast, Midwest, and East Coast all represented here. Welcome, Barden. Great to have you on the call. Before I dive into, I think one of the things that I'm really passionate about is trying to make these, sort of these one-way street webinars much more of an interactive conversation. So it's a lot of fun to just drop in questions or context or reflections that you might have, experiences that you might have in the chat. Spencer and I we've got a bunch of content that we're going to get through, but I'm going to be super diligent on taking those questions that you have as we're going through and trying to get those answered either in, kind of in context or at the end of the call. So please keep the chats wide open and drop your questions in there. Awesome. Well, let's dive in. This is a topic that I'm deeply passionate about. And Aaron, if you go back to the title slide real quick, I just want to say something. Like, I started Nava because I saw and felt the just spiraling cost of healthcare for the average American viscerally, both sort of through my own personal family experience, through my own experience as a CEO of a 800-person company, trying to figure out how do we put a lid on this healthcare cost problem, and through my peer group. So literally, we founded Nava on this premise that we have to do something different to change the trajectory of healthcare costs and healthcare experience in America. So this is just a topic I'm really fired up about. It's foundational to what we're doing at Nava, and obviously, when you hear from Spencer, you hear about how important it is to them. And so really excited about this conversation, and really sort of my goal is to have everyone on this call walk away with a new understanding of a very sustainable way to fund your healthcare and health plans that leads to durable cost savings and better ROI on that health plan spend. So we'll dive into that here shortly. Do a couple of intros. Aaron, why don't you hit the faces slide here? So for those of you that are just getting to know Nava, we are the first benefits brokerage oriented entirely around the mission to bring high quality and affordable healthcare to all Americans. And we're starting with the 160 million that get their healthcare through an employer. We are doing that by bringing the tools and the playbooks from some of America's largest employers down market to the midsize category of companies to make benefits easier for those employers and HR teams, but also deliver more return on investment for that benefits dollar. We all know that I think it's now the second largest line item to spend across most budgets, so it's a biggie. And the number one question that I get from HR leaders and CFOs and CEOs when we're just talking healthcare is how on earth can we save money on our healthcare? I just got my third double-digit, renewal increase this year. I feels like it's Groundhog's Day at renewal strategy time. Just how do we get off this hamster wheel? So we're going to unpack that specific question, and we're really going to focus on an innovative approach to funding your medical insurance. And I'm going to do that with a really great partner in Spencer from Pareto. And both Spencer's company, Pareto Health, and Nava, I think we've got a lot of overlap when it comes to our missions and our whys and sort of just what we're trying to do every single day. So we're going to talk about that here shortly, but maybe before I do, Spencer, I want to hand the mic over to you to introduce yourself and introduce Pareto.
Yeah, and speaking of overlap, I mean, no coincidence, Brandon, you obviously appeared on my podcast. And I say coincidence because we didn't plan it that way, but it happened to come out yesterday. Yeah. So really appreciate you doing that. I think Farzad said he's a fan of the podcast. So hopefully you got a chance to listen to that episode. Lots of overlap. You and I clicked immediately, and I think it was the way that we see this space and the possibility. And I truly believe that employers can turn their healthcare plan spend into a plan asset if they start thinking about it differently. My role in the daily on a daily basis is with Pareto Health as SVP of Consultant Development, which is a title that I usually take 5 minutes to explain, but I'll take 30 seconds. And my job is really to educate the marketplace in whatever capacity I can. So that's public speaking, webinars like this. The podcast itself is a big part of my daily job, and to really act as a force multiplier to raise awareness of the possibilities of what can be done with healthcare if thought about in the correct way and thought about on a long enough time horizon. And so that's what we'll be doing today is really education, Brandon. I hope everybody knows they didn't come here for a 45-minute sales pitch. It really is not that. If we demonstrate through education the possibilities of what can be done with a proper arrangement of a health plan, I think by extension, obviously, they'll want to learn more, but that's the goal for us today.
Definitely. Couldn't agree more. Let's keep going and dive in. I think one thing that I wanted to call out here too is when I think about the levers that we pull at Nava, there's really three big things. There's deliver innovative renewal strategies, on time and save money, provide a benefits back office for HR teams so that they don't have to do that administrative work anymore, running a modern benefits plan, and then supporting your employees year round with a modern benefits experience. This conversation is all about that first bucket. How do we bring more innovative strategies and the vendors that are delivering those to the table to HR teams so that they can sort of get off the proverbial hamster wheel and really, sort of make change inside their organization. So with that, I think we've got a poll too. We want to just get a temperature check from the group on just what are you coming in here with in terms of context. So are you self-funded today? Are you level funded? Are you fully insured? Just want to understand kind of where you stand. Do you have no idea? And that is the totally fine answer to have. But maybe just take a minute, do the poll really quickly. It'd be interesting to see what the results are there too. I had a conversation yesterday actually with an HR team, and they were sort of more in the I'm not sure actually. And I think that to me speaks to an opportunity for education and support there that may be missing. So. Cool. 75% fully insured, and then we've got a handful of self-funded, no one on the level funded side, and everyone knows what kind of funding they're doing.
Yeah. Actually, good to see that nobody answered. I don't know. And it also didn't let me answer. I know I'm a panelist. I was going to answer self-funded to stats a little bit, but that's all right.
Didn't need to. Awesome. Well, let's dive in. Aaron, why don't you let Spencer share screen, and because he'll drive his slides, and hit.
And I'm
going. Cool. Let's kick off.
Yep. Handoff seamless there.
Yes.
Awesome. Cool.
Good to go.
All right, guys. Well, Brandon, thank you for the setup. And I did actually want to comment on your kind of title opening slide. I think that's a really good place to start this conversation from. I think there's a misconception in when it comes to healthcare that I cannot improve the quality of my benefits while simultaneously lowering the cost. I think that's a misconception that's probably been implanted in most people's minds by the traditional purchasing of fully insured or level funded products and kind of the 12-month cycle that we think of in benefits. And so I just wanted to give you guys props that it actually is untrue and we can do both simultaneously with the right strategy. So good job on that setup there and setting the stage. So what I'd like to do now is I used to actually frame this as a statement. And I think as I thought more about this assertion that ultimately this is a question, I think most people by knee-jerk response would say, well, yes, clearly it's broken. But I actually think if we look at it from a different vantage point, I think it's not broken depending on who we're talking to. And if we're talking to the insurers who are large, ultimately publicly traded entities who have an obligation to their shareholders, they're acting rationally, I would say, to maximize shareholder value. And so is it broken? Well, depends on who you ask. And I think it's functioning exactly as it was designed to function. I just think unfortunately for the employers, for the most part, they don't get to participate in positive outcomes in that setup. And so I just want to set the table today. I'm not necessarily going to come here and beat everybody over the head that you're bad or not smart for being fully insured. I would even argue there's a big subsection of the market that absolutely should stay fully insured for a number of different reasons. But for those folks that are wondering, is there a different model out there? Is it possible for me at my size, a 70 life group or a 50 life group, to be self-funded and have the advantages that those large jumbo employers have received over the years? And the answer is yes. And so we're going to sort of walk ourselves through, okay, if not fully insured, then what? And what are the trade-offs? Because everything has a trade-off, and we have to make sure that conceptually, if this does resonate at the end, that ultimately you understand what you might be getting into rather than just jumping into something like this blindly. So
Right.
let's look at the big picture, Brandon. I'm sure you guys have probably used slides like this before. I would say this isn't an uncommon slide to use. But what we're looking at, I know it looks a little bit busy. There's lots of percentages on it, but we call this the alligator mouth slide because it looks like an alligator taking a big old chomp out of the economy. And the reason I like to start here is because when you look at the increase in family premium over the last 20 some odd years, obviously it's outpacing wages and inflation by a multiple, 3 or 4 times margin. And so what that does, and we've got a lot of employers on this call, Brandon, you talk to them all the time. What that does in my mind is creates this tension inside the walls of the employer where a more paternalistic employer that's trying to do everything they can to offer the best possible benefits to their employees is finding that harder and harder to do over time. And the employees that just want decent health care and not only be able to afford the premiums themselves, but actually access healthcare and use their healthcare, that's also being strained pretty significantly. And so it creates this tension from a recruitment and retention perspective that over time, if we don't do something differently, it's going to be even harder to deliver that value. But Brandon, why don't I ask you this? If I'm fully insured
Mm.
and I stay down this path, what levers do I usually pull to try to offset cost?
Totally. Yeah. It feels a little bit like moving deck chairs on the Titanic, honestly, for HR teams. They're like, okay, so we got another 12% increase. We don't know that, we don't have a sense for an alternative. So let's play with contributions. Let's play with, raising deductibles and co-insurance and, effectively skinning the health plan to to get a lower premium impact. And, so it's that sort of impossible choice where, employers are trying to do really great things and good things for their employees. They're having to make this decision around how much of this do I eat versus my employees, and or do I just reduce the actuarial value of my health plans just so that we can reduce the spend. And that's just a really crappy place to be.
Yeah, I would say you're exactly right, right? It's that erosion of the quality of the benefits is feeling like that's the only way I can actually offset the plan increases that I'm having to deliver. And so
Yeah.
whether that's the employer absorbing it, whether they're actually shifting some of those costs over to the employees or the plan design itself, where you said lower the actuarial value, raising those deductibles, raising those copays. And so, wow, that's not something you can do forever because eventually you're going to bump up against those maximums. And the kind of the question becomes, then what? And so that's the aggregate look at things. I would say what I usually like to mention here is that's a $4.5 trillion problem we just looked at. So I don't expect anybody on this call, Brandon and myself included, exactly to fix that today. Although I love your mission to fix healthcare, and I do believe we can do it over time. What I will say is the goal is to get you to lean in a little bit, look at this a different way, and figure out whether or not I could actually fix this for me and my employees, and ultimately the families, by extension, that my employees bring to the table as well. And that's what we're really talking about: is everyday Americans be able to afford healthcare. We try to do this at Pareto, one employer at a time. And so what I want to demonstrate here is something that we call the fully insured stair-step effect. And I know we're picking on fully insured a lot, but I think obviously appropriate for this audience. But this, well, I'll walk you through what I mean by the stair-step effect. And this is really speaking to, Brandon, that difficulty of making those decisions to offset the quality of benefits. And so what we look, if we cast our eyes to the left-hand side of the screen where I see something that resembles stairs, what'll happen when I'm fully insured is I have a bad year, I have a good year, an average year. The presumption is 9 times out of 10, some cost increase will be associated with that. In a bad year, maybe that looks like 25 or 30, or God forbid, I think, Brandon, we were talking about a potential 70% increase that you saw here recently. What that does, though, is that raises now the baseline for the following year. If you have to absorb a 25 or 30% increase, you've now established your new baseline. If you stay in that guaranteed cost, that fully insured environment, your new baseline is here. And so by extension, the following year, you've now got a renewal that's a function of wherever you establish your new high baseline. And so that creates that ratchet or stair step effect over time, where you look up 3 or 4 or 5 years from now and go, wow, how did we get here? Well, the small to medium size increases that we've dealt with. Did I get that right, that quote, or have you dealt with higher than a 70% increase, Brandon?
No, I think you nailed it. And I think that probably the big insight that I just want to make sure that folks leave with here is, I think what's missing in sort of the annual, sort of the annualized view of renewals, which is like, what are we going to do in 2024? And then sort of all context of loss, then you do 2025, is this really foundational point, which is pretty much I would say 95% of the time, the only direction you go is up, and you're up on a new baseline. So you followed that 20%, and then you're high-fiving that there was a 4% increase on next year because you guys absolutely just had an amazing claims year, but it's based off of that new higher baseline. And so you just only go up. And when you actually look at it on a 3 to 5 year basis, which we really orient clients around a longer term view here, the aggregate, which you'll show here shortly, just gets quite painful, right?
I mean, it's an excellent segue. If you look at it at 10-year horizon, it's actually pretty astonishing. I mean, that's really what we compel employers. It's hard to make a decision for 10 years from now. I think 3 to 5 year increments is appropriate, but even looking at it a little bit longer horizon, it really establishes kind of the quantity of the dollars that are being spent over that time. Before we move to that, though, the parallel or the contrast I'd like to describe now is, if I go self-funded, and we'll explain what that means for anybody on this call that isn't familiar with that terminology. But if I go self-funded, what I'm doing ultimately as an employer is deciding to take on the responsibility of claims payments. I will buy something called stop loss insurance, which will cap my risk, catastrophic and overall risk, and I'll explain that in further detail. But just so you know what we're looking at versus the fully insured stair-step effect. When you self-fund, it is possible to have a year that might go over budget. We would say about 1 in every 5 to 6 years, you would have that proverbial bad year that you might experience being fully insured as well. The difference in the self-insured world is, since the majority of your spend is coming from actual claims themselves, and those are variable in nature, and because they're variable, you can now manage them and mitigate them. It is very possible, even in a year that might go above what you might budget, the next year, maybe 1 or 2 claimants leave the plan. We implement a different way to source our medications. We put in a disease management program to address specific disease states. You could actually lower your cost 20, 30, 40% in the following year. It's actually very common. I work with a lot of consultants that will do 5-year lookbacks. I see it all the time where 5, 6 years down the line, that employer is still below the baseline they were when they left being fully insured. And it's because we've now separated our claims from our fixed costs. And so, since you alluded to it, Brandon, I'll go ahead and pull this up. But if you want to comment here, please take a second to do that.
Yeah.
Okay.
Yeah. I mean, this just looks like the long-term view when you actually start to look, over a multi-year view of sort of the stacking or the stair stepping of claims costs. The numbers get quite crazy when you start to look out 5 years and sort of stack up 5 to 25% annual increases through the time. Also, I'd say we keep going. I think Jillian Adams just had a great question in in chat, which we'll hit on. But I just want to call that question out because it's something we're really passionate about, which is she's like, hey, I've been in both fully insured and self-insured environments. And I'm curious how things, in that chart stay below the line mostly. I've never worked anywhere where either model where prices didn't go up every single time. And so big part of the second half is how do you actually reduce the cost of claims? And that's through, cost containment solutions there. So I want to make sure we hit that. But really great call out and yeah, and super important one.
Cool. Well, so what I want to focus your eyes on a couple of things, but let me describe what we're seeing first, because there are, again, a lot of numbers on the slide, but I think it's very simple concept when I explain it. Let's start with a $2 million premium plan spend fully insured employer today, kind of an average mid-sized fully insured employer. And then what we're going to look at is just 9% incremental renewal increases over a 10-year timeline. So 9 renewals, 10 years total. What the industry ultimately will get you to fixate on is like in year 2, it says $4.1 million, but what that is actually the accumulation of year 1, 2 million, and then 2.18 million in the second year. The industry will sort of get you to fixate and focus on, well, what's the delta? Well, the delta is a $180,000 increase, a 9% increase. Most employers will go 9%. That's palatable. I'll figure out how to moderate that, and let's just sign it and forget it. And the industry sort of gets you to think, well, that $2 million as a baseline is a sunk cost. I'm just going to go ahead and assume I'm already going to spend $2 million, but let's add 9% on top of that, and we'll figure it out for this 12 months, and then we'll figure it out in the next 12-month cycle as well. So the reason we show this over 10 years is not only to show, if you follow that teal line, you're going to see my premium on a 12-month basis does double. It goes from $2 million to $4.3 million in that 10th year. So it does double over that time horizon with just 9% increases. But the real reason we have this slide, and we call it the $30 million problem, is that year 10 white bar graph that's over $30 million. What that is the cumulative plan spend over a 10-year timeline if you start with $2 million and just get 9% increases over that period of time. And so if I'm a CFO, or whether I'm HR or CFO, it doesn't really matter. If I were to give you $30 million and put it on the middle of the conference table and say, hey, you have $30 million unfunded liability over the next 10 years to buy healthcare, would you maybe decide now to do things a little bit differently? Or would you make a different decision instead of thinking that as a sunk cost? What decisions can I make today? So 3 or 4 or 5 years from now, I'm actually lowering that overall delta. And so that's really a different way to think about it, is getting out of that annual renewal merry-go-round that you said at the front, Brandon, and starting to think about healthcare as a 3 to 5 or 8 year play or more. So why don't I take a moment, and then after we get from this slide, we're going to start getting into, okay, well, what can I do, right? We're really hammering the problem. Now we're inching our way towards, well, what is the solution? What is self-funding? And then a captive specifically as a vehicle. How could that help a smaller to mid-sized employer stabilize being self-funded over that time? So on the left-hand side, we have that fully insured gray bar. What I'm trying to demonstrate here is inside of your plan today are claims. That fully insured carrier is obviously trying to project what your claims are going to be and build premium that's available to cover those claims. You're paying for administrative expenses. You're obviously paying taxes inside of that premium because they have to pay taxes on your behalf. And then ultimately, what you're also baking in is a presumption that that carrier has margin built in as well. So that's their profit. When you look at a self-funded plan, you're still going to have claims as the majority of your spend. But the difference is we've now liberated our claims from that guaranteed cost environment, and we've turned those claims into an opportunity to not only measure, but manage them as well. You will have a much smaller percentage of your plan spend go to fixed costs. So that's administrative expenses for like your TPA, your third-party administrator, your PBM, who's managing your pharmacy claims. And then if you manage your plan effectively, rather than what's left over at the end of the year going towards that carrier as profit, you now as the plan sponsor get to keep those dollars inside of your plan and deploy them as you see fit. So we don't turn that into a profit center for the carrier. We keep those dollars inside of our plan, and it's our business to use those dollars for healthcare in the future. So Brandon, any call outs there? Because I know conceptually we need to make sure people can differentiate those two models inside of their head. Okay, cool.
Correct.
So you might ask the question then, well, okay, why wouldn't everybody else self-fund, right? I mean, I think that's really common. We get to this point, people go, well, at least the concept makes sense. So doesn't everybody do this? The answer is, I think 2/3 of employees in the United States that get their care or their health insurance from their employer actually already are self-funded. But the majority of those businesses in the past have been the large to jumbo size employers. So what would stop a small to mid-size employer from becoming self-funded? Well, we start to concern ourselves with really big claims. I think if you've ever heard anybody on healthcare speak, they keep talking about the rise in $1 million claims or the rise in $2 million claims. There's some really big risk that's out there. And so a traditional arrangement outside of a captive might seem too volatile for that smaller to mid-size employer, mostly because of conditions like you see on the screen. So cancers, heart attacks, organ transplants, hemophilia is a really common example where the drug spend can be significant. This idea of what's called a laser, which is a larger exposure for a self-funded employer that the stop loss carrier is now deferring back to the employer to take on, those lasers have been that preventative mechanism. And as we get into our contract later, how do we mitigate and how do we prevent those lasers from happening? It's a really important call out, at least right now, to explain this has been the main hurdle historically for employers to make this transition. How do you feel about that slider, Brandon? Any comments you want to make?
No, I think that's good. I think there's sort of two objections that we, that have sort of been the hurdle. One is sort of how do I mitigate this sort of like catastrophic possible downside risk, which we'll get to and we'll address. And I think the second one is just, hey, what's the complexity, right, of doing this? Hey, yeah, I'm an HR team of 3. We've got, we've got a lot of things on our plate. So we'll hit on that as well as we go through the conversation. So I think this is great on the concept.
Yeah, that's absolutely. And so when we get into this idea of reducing risk and lowering costs, which is sort of part of our mission, Brandon, I'll weave that in throughout. I think that's where obviously good consulting partners come in. And so I'll go ahead and call that out right now. We've developed a partnership with you that I think is burgeoning, is going to grow significantly as well. But it's our job as Pareto consultants is to identify those consultants that have the acumen and the capacity to do things like this. And really, it's about establishing a strong partnership with great consultants first, because ultimately, and I'm not meaning to kick the can over to you, but a lot of those questions around the complexity or the effort will end up landing on Nava's plate as a result of that.
100%. Yeah.
You build the framework and you help deploy it, right?
No. Yeah. Our answer is like your great benefits partner consultant should be abstracting away that complexity. It's foundational to what we do on the, on the Nava side of the house.
Yeah. So, and I appreciate the call out here. Mission. We are a mission-driven company. If you ever hear our founder speak, it's a pretty interesting founding story that I won't ultimately deliver here today. But it's more just like you want to fix healthcare, Brandon, at Nava. I think what we're doing is a mission to do exactly the same thing. We've just landed on the captive vehicle itself being the most efficient way to deliver that outcome. And so it's a 2-part mission. You guys can read the screen, but really what it is about making self-insurance simpler and more accessible. So that's mission number one. How do we finance healthcare in and of itself in the most efficient way possible over time? The second part, which I think, Brandon, you mentioned earlier, we cannot do that if we also don't help these employers control the cost of claims. I mentioned a few slides ago, 60 to 70% of your plan spend when you're self-funded is your actual claims. And so I look at that not as a burden, I look at that as an opportunity. If I know and can now see the source of some of those big cost drivers, I can do things to alleviate those costs rather than keeping them trapped inside a fully insured environment where I really am ultimately flying blind. So this is a self-reinforcing mechanism where if we have the first part and we don't do the second part, the captive probably doesn't exist as we know it today. And if I can't do the second part, again, vice versa. Those two things have to be deployed together so that this thing can remain healthy and continue to grow at the pace it's grown. So we'll focus on mission number 1 as well. And Brandon, I'd love, for you to weigh in, because when we get into cost containment, ultimately, there are probably things that Nava does that we don't do. And so one of the things I'll make sure to stress, everything that we do deploy from a cost containment perspective is optional. And if there are things out there that you're using that are better, like go ahead and use them, and we'd be more than happy to underwrite those things as well.
100%. Yeah. Let's dive into this managing the volatility, objection. Then we'll hit that.
So volatility. When I'm self-insured on my own and I'm small, I have to deal with a significant possibility of volatility because I don't have the stability of a large or jumbo size employer. And so what a captive does is answer that question. How do I achieve greater scale? And there's a lot of numbers on the screen. I won't read them all off to you. But just so you give some context, Pareto is larger than I think all the other captives combined. And so that scale, when you worry about, well, how big is it? That's really the main question I would ask when I'm investigating a captive is how big is it? And is it going to be sustainable over time? And so you can see the 2,800 is actually closer to 3,000 members now. It's over 1 million covered lives. And so that scale would give you the same buying power and the same stability as an Apple or, I don't know, you name it, Fortune
Yeah.
5, Fortune 10 company. And so that's what an individual employer that joins something like this, they have the ability to now achieve a similar level of scale and stability that they would not have on their own. So, Brandon, commentary there, because I think there's a couple things I can call out here. Some of them will be addressed later, but is there anything that jumps out to you on this screen or you want me to address specifically?
No, I think this is, I mean, the thing that I just emphasize is the scale is the real sort of captive lever here, that creates the opportunity. If you're we're a 75 employee company or a 300 employee company, stepping into this vehicle enables you to, from a purchasing power standpoint and a risk distribution standpoint, look like a million employee company, which is just that is the magic of sort of what the largest organizations in America are sort of leveraging to just definitively spend less per employee on better healthcare. So we can keep going though.
Yeah, and the last thing I'll call out, and really the one that I think we would be most proud of, is there are some other captive arrangements that are fine, but they might also include either longer term commitments or ultimately there might be some penalties for deciding to exit the captive. And so that 97% that you see in the center, or 96%, excuse me, that you see on the center of the screen, that is meaning 96 out of 100 employers decide to stay without any of those constraints. And so year after year, they vote with their feet, and 96% of them decide to stay because it is delivering the value that they expected. Plan a little kind of placeholder in your mind of the 0 new lasers and the 30% rate cap, because that's going to come up later as we explain that. So I think if there's any
and I know Kathleen,
go ahead.
Real quick, actually, before we jump, Kathleen had that question. So about, if you have one of those lasers, will the captive drop you? Kathleen will hit on that. That's actually one of the sort of big value propositions here. Kathleen asked a good other question though. It was kind of what I think about too, is like, those 4% that have not retained, why did they leave? What are some of the most common drivers for?
Well, one of the most interesting things, and I think I'll go ahead and Kathleen, I'll address the concern over being kicked out. People always ask the question, well, do you just kick out the 4% that are running? The answer is
a bad year.
No. The captive is designed to absorb the costs of those employers that are running poorly. The majority of the reasons why people leave, and Brandon, you've kind of seen this world before, these are M&A activities. So mergers and acquisitions. These are small companies that be absorbed by larger companies and end up getting folded into their healthcare plan. And so that is really the overwhelming majority. Some people do leave for whatever reason that's probably specific to their own decision-making process, but it's not a result of, we just got rid of the worst 4% performers and tried to pretend we were better than we are.
No, I think that's a great call out. Just one thing that I will say from our seat as the benefits consultant representing the employer, effectively as our fiduciary, partner on this, is education is just critical. That's why we're having these sessions. It's the more that the sort of understanding is there in terms of how it works from both an HR and finance standpoint, the more just confidence there is. And we're stepping into just a systematically more effective structure than we were in. But where there's education gaps, and we've actually, we've been brought into new clients who are like, we didn't even understand what self-funding really was before we stepped into that. And we had all kinds of problems downstream as a result. And so that's a big opportunity, a big challenge for organizations.
I would say of all the slides that I want to make sure that I really keep people here and capture your understanding, it is this. Because we hear the word captive, and a lot of people kind of get scared of that idea. Captive sounds like you're, locked in a cage, or we're holding you hostage, or something like that. And the captive word in of itself, we often try to, avoid as much as possible, because we really think about it as a community of like-minded employers that have banded together, to use that purchasing power and to share ideas as well. But if I can give you an analogy that I think will, at least the most simple way that I can explain what it is, so that way, if you ever had to tell somebody over a cocktail, although you probably at the cocktail party run people off, what is a captive? I'll explain it in the simplest way I could. So if you were to picture like a Home Depot bucket, those orange 5-gallon Home Depot buckets, and we put it on the center of the table again, what we do with our captive members, they'll all have their own stop loss policy. They all have their terms and conditions, their own premium, but we aggregate those premiums and we would put it inside of that proverbial Home Depot bucket. And then throughout the year, our job as a captive manager is to reach inside of that Home Depot bucket and use those dollars to pay claims. But the captive allows us to diversify the risk across that entire pool. And so that risk now becomes shared across the community itself. And it's a lot easier to underwrite, $1.4 billion in stop loss premium than it is to underwrite individual cases. And so we'll reach in that bucket, and our goal is to have 5 to 8% left over at the end of the year. We feel we've done our job if we have a little healthy margin that's sustainable. And then we'll also deliver some of that back in terms of profit sharing back to the members at the end of the year, assuming we have that profit. We have had a profitable year in the last 8 years. And so that gives us a really, really healthy position from a financial perspective because of the scale that we've achieved. If we shift to the right-hand side, though, moving away from the bucket and just think about that volatility component. I like to describe volatility and self-insurance on your own as similar to the EKG effect. So if you're hooked up to an EKG machine and you have your heart rate on the monitor going up and down with the peaks and valleys, oftentimes you will see a similar peak and valley being self-insured on your own. A captive does not eliminate your risk, but it makes it more predictable. So those peaks and valleys are much more sustainable over time, almost like you went from waves cresting now to really slow rolling waves instead. That is, if you remember my finger dancing around the screen, ultimately that's what a captive is set out to do. And that's what we do here at Pareto. Okay, so let's get into the contract. For those of you, I think 25% of the group, if I recall correctly, Brandon, was actually already self-funded. And so I'm going to use some terminology that pertains to stop loss insurance that should resonate with those folks, but I'll do my best to bring everybody along as well. And so we offer something called a 30% rate cap and a no new laser provision. And so I'll explain those two things separately. The no new laser is that provision that prevents those large catastrophic claims that I mentioned earlier, those lasers, which are those really big claims. That no new laser protection prevents you at renewal from ever having one of those applied to your policy. And so what that means is we now prevented you from having some unforeseen, very, very big exposure as an employer. But a no new laser contract isn't really good unless it includes a rate cap provision as well. And that is how we cap the actual premium increases. And so let's separate something real quick, Brandon, because we were talking about fully insured stair-step effect before. In a fully insured environment, if I get an increase of 30%, that's my overall spend went up 30%, which would probably be catastrophic financially. When we talk about a 30% increase in stop loss premium, our stop loss premium might equate to 25% of our plan spend. And so in reality, 30% increase to that 25% is realistically only about 7.5% of overall increase. And so I really want to make sure we separate those two ideas.
Yes.
Yeah. So yeah, adequately, because I know we wanted to explain that. Did I do an adequate job in your mind?
You did. Yeah, absolutely. It's super key. I think that, and maybe what I think is really, really interesting here. I mean, that no new laser, I mean, we do a lot of self-funding work for our clients. We're out there getting ASO, self-funded quotes, just, even in the market, we're inheriting or bringing on clients that are on self-funded platforms. The no new laser sort of feature is totally unique in the marketplace. That is a huge deal for reducing volatility and risk, and it's just something you don't get in a sort of a standard self-funded component.
Yeah, and even if you do get it, you won't get a 30% rate cap attached to it. And I think the big difference, and this will get a little nuance, but I think it is really important to call out.
Yeah.
In a traditional stop loss purchasing arrangement, you might get a no new laser and let's call it a 50% cap. The big difference between them and us is that feature can be pulled at subsequent renewals. So what will happen is if that plan is performing really poorly, the carrier will say, well, we'll keep you as a client. We're going to raise your costs, but we're not going to give you those same protections that you used to have. And ultimately that employer is going to be exposed. Our captive agreement does not allow us to ever issue a new laser or ever issue an increase above 30% for as long as they're members. And so that in perpetuity component is hugely different than the regular market.
Yeah,
so
and that's what was so attractive to us. And I think I want to Kathleen's asking great questions that probably other folks have had. I think a couple of clarification questions for him. So what about maybe thinking about the like natural volatility of just being an employer, running an organization? What about a change in business, a loss of 30% of your members, maybe due to reduction in force or separation from the company? So hit that, like what is the possible? And then I think a clarification question on the still no laser or no more than 30%. What about a reduction? And I think she might be actually talking about, stop loss premium.
Yeah, well, that's a good call, and I've actually asked my marketing department to update the slide because
Totally.
you absolutely can get a reduction. And I think I heard 75 plus employers last year did actually get a reduction in their premium as well.
Yeah.
And so it's a little bit of a misrepresentation to stop that at 0%. What we're realistically looking at, Brandon, and I'll get to the other question, which I think was about, what was her first question, Kathleen's first question?
Was like, what about a change in business, a loss of
yeah.
30+% of members? Like, how does that impact my sort of membership into this coverage?
Sure. And I think almost every stop loss contract that I've ever seen, if there's more than a 10% change in enrollment in the year, they have the right to re-underwrite that case. It doesn't mean they'll execute on that right, but they do have the right to do it. If you see a 30 or 40% change, that probably is going to be re-underwritten because it's almost an entirely new risk pool at that point. And so you may see that happen, although those things don't happen all the time. So I would say it's a relatively rare event.
Yep, I agree. It's an underwriting trigger.
It is an underwriting trigger.
Yep.
So, all right. So I'll finish out this slide, and then I want to get to obviously the cost containment side. And I know we've got a bunch of questions coming in. But ultimately what we're doing is those in a normal world, if you're running really poorly, you could get a 70, 80, 90% increase on your stop loss. What we've done in that yellow wedge is we've lopped it off. And so we'll get the question, well, how come Pareto's been able to do that and nobody else has been able to do that? And so the answer is, if I click one more time, you see that teal little line that just got smoothed on top of that wave. I think of that as smoothing peanut butter on a slice of bread. What we're doing is spreading about 2% of premium across 3,000 employers. So we're loading the premium in order to be able to offer a rate cap that nobody else is able to offer in the market. And so what I will immediately say is, if you are an employer that's ultimately chasing the cheapest possible stop loss contract or the cheapest possible rate, you'd probably be disappointed when partnering with Pareto. So that's not to say we're wildly expensive. We have to be competitive just like every other partner has to be. But we want to partner with employers that understand there's value in enhancing this contract. And I'm okay with spending a couple more points in premium, because I know in that worst case scenario, and I've seen some pretty bad scenarios, in that worst case scenario, I bought the insurance today to do what I expected to do 2 or 3 or 4 years from now. And so I want to make sure conceptually people understand I could sell you cheaper insurance, but that's not the point of what Pareto ultimately does. So let's look at like brass tacks.
Get to the bottom line. Yeah.
Yeah. So I think if we look at brass tacks of what an employer might expect, since I've got 3/4 of the people on this call are in a fully insured arrangement, we actually studied our block of business over a 5-year time and said, well, what happened? How did these employers actually perform? So what we're looking at is employers that move from a fully insured arrangement into the captive. After year 1, what was the actual outcome? And so the average savings was 7.5%. But in reality, 4 out of 5 of those businesses saved more than 10%. So that was more than 10% versus their fully insured renewal. And so we'll often get the skeptic, and I'm a little bit of a skeptic myself, and says, well, are you hiding what happened to the other 18% that quote unquote lost money? And so the next slide will show we did actually demonstrate that as well. Worst case scenario, we saw an average of a 3.7% loss. And all that loss really means is you spent 3.7% more than your fully insured renewal. But in reality, risk doesn't happen in a vacuum. And so that next box that's showing you what would have happened had they stayed fully insured and had a similar claims experience, their renewals 25 or 35% increase. But again, that's all of their premium because they stayed fully insured. That's the ratchet effect that we're trying to avoid. And so I look at it from a CFO's lens is, I've got an 80% chance of saving upwards of 10% or a 20% chance of spending 3 or 4% more. That's a value proposition I would probably undertake, especially because now there's the possibility of saving money that didn't exist prior to that. Cool. All right. So I think I beat a dead horse here. So let's move on from the stop loss piece and let's get to the other side of the equation, which is part B of this mission, which is controlling the cost. So there's the logos that I was talking about earlier. And why do we bring these up? The size thing again, because that allows us to go to market and use that leverage to get point solution partners that normally would be only for the large market. We bring those downstream, and then we use a leverage to spread the cost. And we actually even help buy down the cost of some of these solutions so we can bring them at a very low price point down market to the employers that we work with. And so what does that look like? There's a couple things I want to call out here. This cost containment, or we call it ICM, which is our integrated cost management toolkit, is optional. Again, if you don't like anything that comes with it, you're welcome not to use them, but about 60% of our partners use them. Reason being is, hey, we're already looking at making a change and being self-funded. I really would like some recommendations of what are the things that Pareto has vetted and validated will help me save money. Why would I go spend all the time and energy to try to do that myself? Why don't I just assume that they did a really good job of putting together that toolkit? And so, 60% use it. But what we're talking about is a couple things. Integrated point solutions. So how do we connect them with their TPAs and their PBMs so that we can prevent things or see them as they're happening? Then how can we intervene? So if it's a high cost claimant or it's a situation where we want to put together playbooks or strategy alongside you at Nava, we'll actually look at our own data to give each employer, customer of ours, a forward looking, here's what we think is a blueprint would be a good idea to start rolling out. Brandon, I want your perspective here. If you're
Yeah.
thinking about the mind of a fully insured employer transitioning into something like this, and we usually think of it in the context of crawl, walk, and run. But what would be your sort of opinion on like how far to go early on, or do you view it as an incremental change over time for most employers?
We definitely view sort of crawl, walk, run as sort of foundational here. Kathleen, we'll get to your question around average cost savings and these extras,
Yeah.
and a couple of examples here, but absolutely. And I think really this is where it's like once you've got the right funding structure. So we're now, we've kind of evolved, like we're in the captive structure, we're getting the benefits of sort of looking like a million employee, Fortune 50 organization. Now we start to look at where are the biggest opportunities for return on investment or cost savings and improved health outcomes for the specific employee population that we're dealing with. And organization A will be totally different than organization B just based on their demographics. We've got clients in the manufacturing space with a lot of field workers, and we've got high growth technology startups that everyone's remote working, knowledge worker jobs. They're going to have different needs, and so the sort of kind of playbook here is like, let's evaluate those needs and stack rank where the biggest opportunity is, but then take it on a sort of a multi-year crawl, walk, run basis in terms of which of those we bring in. And what gets me really fired up, and this is sort of kind of the core thesis behind Nav, is like, man, now we have access to benefits that no average 100 life group would ever even have access to because they don't even meet the minimums of that vendor. And now we can step into that. And we can bypass that, not to mention get better contracts and better pricing. So anyway, that's how we think about it. So for example, we have a client that's really just focused on, hey, I just want to get my employees focused on primary care, preventative maintenance. 60% of my employees don't even have a PCP. Cool. One medical or that type of solution, very interesting opportunity for us to like really drive sort of behavior in that direction. Others have like, hey, we have a cancer problem. Actually, the claims bear that out. Let's look at cancer care, et cetera, and bring that in.
Yeah, and I love that, man, because I would actually lean towards the side of crawl, walk, run as well. And in the interest of thinking about crawling, I'm actually going to start on the pharmacy side, Brandon, because I think that would include crawling. Honestly, I really think that's where the lowest
kind of where we start, honestly.
Yeah, that's where you start.
That's where we start, where the lowest hanging fruit is, or I'd frame it another way, where the most egregious overcharging is for the average employer that that we work with.
That's absolutely true, right? And then so that's why we went to market and said, how can we not only secure better pricing, but actually draft better contract language that advantages the employer? And so you look at there's 4 on the list. I'll call out some Smith RX just because I'm familiar with them. And ultimately, I think we have about a third of the block of businesses with Smith. They're great, but they're really what I envision a modern kind of lowest net cost focused pharmacy benefit manager. And so I could spend a lot of time on them, but the point is, they operate in a completely different model than the typical rebate model that your traditional PBMs operate in. Their job is solely how do we deliver maximum claim savings to the employer, and they get paid on a PAPM basis instead. So they're now aligning proper incentives. And to swap one of these things out, a new pharmacy benefit manager, assuming the TPA and their size allows it, which there are some constraints, that is where I would probably start. If I want to take those claims head on, we usually communicate conservatively. There's 25 to 30% savings on your pharmacy just by partnering with somebody like SmithRx with one of our contracts. So that's where I would start if I was like, I'm only going to pull that lever in year one.
Yeah. And what, maybe just put that into context. What does saving 35% on your pharmacy equate to in terms of your overall, healthcare spend?
Yeah, it's going to be about 5 to 6% or more, depending on, most employers have about 35% of their plan spend as pharmacy. Some of them have closer to 50%. And so I would just look at, if you can get access to your data to contextualize it for yourself. But we're talking a decent chunk of your overall plan spend could be flipped overnight.
We see 5 to 10% is sort of the
5 to
range
10.
that we see on overall plan spend. Yeah.
Cool. And so on the pharmacy or on the medical side, you mentioned you called out One Medical by name, which I think is great, Cancer Care by name. One thing that I think people don't often think about is those middle layer claims. So not my really huge catastrophic claims and also not my going to the doctor routine copay style claims. And so I want to call out KissCard that's been bought by a company called Valence, but still operates the exact same way. KissCard is a direct contracting network where we've actually worked with KissCard. They have their own network of physicians and MRI locations, facilities where something like an MRI, where normally you might get referred into somebody down the hall that has an affiliation with that primary care provider. They send you down the hall, you get an MRI, and you find out 3 months later that was a $3,500 MRI. What KissCard does is say, well, we'll just actually directly contract with those facilities and we'll work with the member to say, hey, we saw that you have a pre-cert for an MRI. Here are 3 options we have within a 2-mile radius where you could go. And oh, by the way, it's $400 or it's $600 instead. And what will typically happen with employers, they'll actually waive the out-of-pocket expenses altogether for those types of claims. So the member, so the employee themselves, has 0 out of their own pocket because they made a slightly better, or if not a significantly better choice of consuming care. And so it's a different way to think about how do I navigate through this? And this is where Nava and your healthcare navigation platform comes in to be really effective. Yep. How do I navigate through this complex thing and what tools are available for certain components of the healthcare continuum that I could easily deploy inside of my plan today? KISS is just a great example of something that's very simple to do.
Love it.
So we'll wrap up. I think Kathleen was asking, like, do you give discounts or decrements for these things, as we call them in the stop loss world? And so we do have TPAs, although you can work with your own TPA. That's perfectly fine. We certainly have TPAs that are preferred for a number of reasons. And I don't think it's a completely comprehensive list, but these are the most popular. And so we prefer them simply because 1, they know how to execute on our arrangement. 2, they usually offer dedicated service teams and standard pricing as well. But it really comes down to the connectivity. I didn't mention Springbuk a moment ago, but if you use our ICM platform, you get access to Springbuk, which is a data analytics platform. And so there's seamless synchronization between the data flows there. And so we do actually incentivize these choices, again, because we know they work. And so you can get up to, I think, 6 or 7% discount on your overall plan spend for stop loss if you use some of these things. So yes, optional, but there's a reason why we want to incentivize those choices because they're effective.
Yeah. I think a related question, which Kathleen might have been getting at, is like, do you have any hard examples of actual claim spend reduction as a result of cost containment solutions, which is sort of that's what they're here for. Maybe
you want me to give you the most extreme example I've heard?
Yeah, no, give us some hard data, because that's what everyone sort of, I think, has like a hope for, but especially in the mid-market, they're like, I have no idea how you go from theory to, to reality. So give us real examples there.
So here's a real example, and I'll use SmithRx because we use this as a case study, actually. So SmithRx helped us with a group that we brought into the captive that had a hemophiliac on the plan. And their traditional pharmacy benefit manager was actually putting that plan spend at $2.3 million just for the drug that hemophiliac was on. SmithRx got engaged and was able to get that for $850,000, which is a huge savings in and of itself, but it's not where it stops. SmithRx then engaged with the member and found out that they actually qualified for something called the Patient Assistance Program, which is a needs-based program where the manufacturers will actually waive the cost altogether if they qualify. So Smith walked that individual through the paperwork to qualify for PAP. And ultimately, that was a $0 cost to the plan and was a $0 cost to the member. And so you can only do those things if you have line of sight into the possible pathways to go. And I know that's extreme example, but that is a recent example and one that's obviously saving that employer millions of dollars as a result.
Yeah, I love that. I think one of the things that it may be a concern that is unvoiced on this call and that,
Yeah.
that I hear from is like, but like myself and my HR team are going to have no idea about this patient assistance program or how to, how to navigate from point A to point Z here. Maybe you
Yep.
can speak to sort of, I think that the navigational and guidance component of sort of this whole thing is really compelling. And I think an important point. Talk to that. And I think Jeremy on the call also asked the question, how successful is KISS card at getting members to follow the recommendation? So they're connecting the dots on how do we go from, logos on a slide to
Sure.
real people getting the outcomes that we're talking about getting.
Well, so that I think I'll address the second one because it's a little bit easier first to
Yeah.
address. Is like, how would a KISS card get engaged? That's
Yep.
one of the big reasons why you might choose one of these platform TPAs is because of the integration of that data flow. We can seamlessly and automatically trigger that event and that outreach to the member. And I will say too, Brandon, I know you guys do a good job of this, but effective communication with the employees that these things are available. We actually have a buy up of something called HealthJoy, which is a benefits wallet and care navigation platform that puts it all into one spot. And so I have it on my phone right now. Pareto uses it ourselves. That's right there. I press a button. They say, what do you need? Or they will actually text me or call me if an event happens that's a proactive outreach, and it comes right to my phone, and they're talking to me about my options right there on my phone. And so there's a little bit of training, there's a little bit of communication and education required, which is again where Nava can play a significant role. But the idea is, how do we recreate your easy button that you have today being fully insured, but actually deliver you cost savings simultaneously? And that's where picking and choosing those right vendor sets are crucial. To the question about complexity, this is where we work in a limited distribution model. This is where having the right consultant is immensely important. We realize that there's a lot of new ideas that I've just covered over the course of the last 45 minutes. And some folks may leave going, wow, that sounds overwhelming. The good news is we've done this over 3,000 times. We've gone through 8,000 renewals. We've done it with employers as small as 37 lives, as I've seen this year. And so the good news is those employers are capable of doing it. It is especially because that they're working with a great consultant as well. And so I'm going to keep obviously tooting Brandon's horn, but it's really important to stress that particular piece.
Yeah, no, I think that's foundational. I think there's two things that got me and continue to get us so excited about what we're talking about here is one, Pareto paired with a great consultant, they've done the heavy lifting. Like the contracts, the pricing, sort of navigation and support is built in, for example, with SmithRx. But I think number two, it's like, I look at Nava or your benefit consultant's role as we are the integrator. Like our job is to abstract away the complexity around standing this up and then ongoing, what we call sort of advocacy and support, which I called out a little bit in the chat with the Nava benefits app and advocacy team. Why don't you close this out? We got 3
Yeah, I would
minutes.
say, Brandon, I was going to look at the time, and this I think slide speaks for itself, but what we're looking at possibilities going self-funded and then agreeing the possibility of adding the cost containment on top of that, what is very possible and probable as an outcome over that 10-year horizon. What I want to do though is kick over to what is the point of this whole community? We use the word community for a very good reason, because it is a member base, and this is actually a member-owned captive. So each employer that joins becomes an actual shareholder of the captive themselves. Pareto doesn't own the captive. And so a big part of this is, what am I getting out of that membership? And so it becomes, we have discussions, and I've got on the slide a couple of opportunities for folks to come to a prospective members meeting and see what it's all about. But I truly believe when you get those employers in the same room and they're hearing from employers that have done it before, and they're also sharing ideas because they realize I get to join a risk pool intentionally, and I get to join a risk pool with people that want to do the same things I'm trying to do with my business as well. I think that's where things really click, because they realize they're part of something much different than they've been buying before. And so I will close it with that, is that there's going to be a call to action if we want to connect with Nava and our sales team. But ultimately, if you have a chance and we get down the path, I would strongly encourage you guys join one of these prospective members meetings on the screen.
Love it.
So
Well,
I'll
why
turn
don't
it
we
over
close
to
out?
you. Yeah.
First off, thank you, Spencer.
Yeah.
It's truly a pleasure just geeking out on this and sort of diving into this concept. I deeply believe in it. I think sort of one call to action. If you're interested in learning more could just be, hey, I just want to double click to, hey, we're moving into renewal season, and I want to compare this side by side with my fully insured renewal or self-funded status. Either of those, we can help you on that front. Just shoot me an email, brandon@navabenefits.com, and we'll coordinate and get you connected with the right folks. And I hope that this is a takeaway. This is a drum that we're going to continue beating, because this is truly the way the most sophisticated organizations in the country are choosing to fund and then deploy and then serve their employee populations on benefits, and it's saving the money. And our goal is, how do we make that easy and bring it down market to employers like those of you that are on the call? So really excited. Hopefully you walked away with more knowledge and hopefully some excitement around the opportunities to, what I would say, get off the hamster wheel. With that, Spencer, thank you so much. Thanks to everyone who joined. And have a great rest of your day.
Yeah. Thanks, everybody. And thank you, Kathleen, especially for all the great questions.
Yeah, great questions on the chat.
See you
Awesome,
guys.
guys. Take care.